Going live now. There we go. So now we're streaming live on YouTube. Okay. Make sure that chat is enabled. Okay. All right, I think we're ready to begin. It's 7:01. So good evening, everyone, and thank you for joining us tonight. My name is Ravina Nimbalkar, and I'm the Executive Director at NAMI, Santa Clara County. Before we begin with our presentation tonight, I'm just going to go over some of the updates at NAMI, Santa Clara County. Our helpline is up and running from 10 a.m. to 6 p.m. Monday through Friday via phone, as well as we have walk-in hours from 10 a.m. to 2 p.m. We do have after-hour family support, which is available on evenings and weekends. Support groups are all listed on our website and are offered over Zoom as well as in person. We have some hybrid versions too, so you can just check our website, which is namisantaclara.org, to get more information. Our education classes, such as family to family, familia to familia, persona to persona, peer to peer, provider education. To get on the interest list, you can call a helpline number, and the helpline number is 408-453-0400, and you can select option 1. And you can put your names in interest list, and then somebody will get in touch with you soon. Our NAMI Basics program, as well as NAMI Homefront, is online and on demand, and it's on our website. You can take it at your own pace. The next FaithNet Mental Health 101 is going to be on May 22nd. Again, you can call a helpline and somebody from the FaithNet team will be in touch with you if you're interested. Our community peer program continues to match via hospitals as well as self-referrals. You can, the form to be part of it is on our website. For a little bit of fun, some information. NAMI is celebrating 50 years this year, and we are going to have a 50th anniversary celebration this coming Thursday. Other tickets are sold out, but if there is anyone, if you have any unpaid guests still interested in attending, you can contact Christina at K-Alaniz, that's K. I'll put the email in the chat as well, KALANIC@namisantaclara.org, no later than tomorrow at noon, because this event is on this coming Thursday. And we will see if there is any spot has opened up from the wait list, because we do have a wait list. It's going to be a fun event with raffle baskets. We're going to have a silent travel auction, and our keynote speaker for the celebration is going to be a former Senator Jim Bell. Okay, so before I invite the speaker for tonight, I would like to conduct the installation of the Board of Directors for NAMI Santa Clara County for the year 2025-2026. Our board officers for 2025-2026 are: President is Uday Kapoor, Vice Presidents are Beverly Lozoff, Juan Perez, Frank Aliotto, and Maureen Milo. Treasurer is Scott Welton. Secretary is Peter Newman. Our board of directors consists of officers and members at large. Officers are listed, I just mentioned above, and our members at large are appointed by the president, and they are Karen DeLume, Gillian Van, Dolly Sandoval, and Dr. Hogan Shai, and our past board president is Vic Ojakin. Okay, so moving on to our presentation, by popular demand, tonight's general meeting is going to be the Ask the Doctor. I know you all are waiting for that. Our presenter for tonight is Dr. Rona Hugh, and she is briefly going to be speaking about schizophrenia and bipolar disorder and spend time answering all your questions. Dr. Hugh is a medical director of acute psychiatric inpatient unit at Stanford Hospital, specializing in care of those with serious mental illness, including schizophrenia, bipolar, and depression. She completed her medical school and residency in psychiatry at the University of California, San Francisco, and fellowship in pharmacology and schizophrenia research through the National Institute of Health. She's also active in the minority issues and cultural psychiatry and has received regional and national recognition for the clinical care, research, and teaching. With that being said, I'm going to pass it on to Dr. Hu. Our meeting tonight is being live streamed on YouTube, so you can always go back and refer to this meeting on our YouTube page. You just look up NAMI Santa Clara. And if you have questions, feel free to put them in the Q&A sections. And if you have comments, you can put them in the chat section, and we go over all of them. So over to you, Dr. Hill.
Thank you so much, Ravina. And thank you for one of the NAMI members who invited me, and it's an honor to be here. I'll start with a little introduction about what I do, and then you can ask whichever questions. I'm always happy to hear questions. If I don't know the answer, I'll let you know. And of course, these are general questions and not necessarily. I'm not, unless I already am your doctor. I'm not your doctor. So I can give advice to the best of my ability, but it's not a substitute for medical care. I've been a psychiatrist. Gosh, I guess I graduated from medical school in 1990, and then was a resident for 4 years. I've been at Stanford since 1998, so that's more than 25 years now. I was medical director for 20 years, from 1998 to 2018, at the inpatient unit, the locked unit at the hospital. And before that, there were 12 medical directors in 20 years. So I don't give up easily. And you might think that I'm very stubborn. So, it's very important to me, what I'm doing, what you're doing, what we're all in together. I won't do a long talk about some of the reasons that I went in, but I did have a friend from high school who went to an Ivy League and then to medical school, and then arguably the most prestigious medical school in the country, Johns Hopkins, and then developed schizophrenia, and then died by suicide. I also had a friend from medical school who I dated and who had bipolar disorder and then left medical school. That's been written into a performance as part of the Manic Monologues, and it's called Bipolar Boyfriend. So that was, I guess, nominated for Best Digital Theater by Broadway World during the pandemic, and has been performed in different countries. So I've done some consulting for different media, including the very controversial 13 Reasons Why, the first season only. And then, but my day-to-day, what I do every day is see patients every day. And that's, and I've gotten awards for teaching. Let's see, if I did 25 years and basically saw all of the residents that came through Stanford, that's 12 times 25. What is that, 300? Did I do that right? And then twice as many medical students. So I've gotten awards for teaching, I've gotten awards for research. And then when there was a shooting in Half Moon Bay, I went out there every day for the first couple of weeks, and then once a week and so forth. And so I was given an award for patient care that wasn't, that was not part of my job. So that's a little bit about me. And I'm seeing questions come in already. So when I've done talks with PowerPoint before, they were fine, but I think what's most useful, because you can look up a lot of the sort of PowerPoint things. I think what's most useful for the time that we have together, which is limited, I think we have until 8:30. Is that correct?
Yeah.
So, good. So a little under 90 minutes. Um, so, you know, I I deliberately didn't prepare. Well, first of all, I had less than a week to prepare, but also I have never, either with my medical students or with family members or anything, I've never had anyone said, "Could you please do more PowerPoint?" So we'll start in on the questions. I see both chat and Q&A, and I think Ravina and I will sort of tag team to make sure we answer the questions. So I see keto diet, mitochondrial health, and then in chat, I see wait list, address how medications have changed for bipolar and improve over time with less side effects, and what's your experience with Cobenfy? Okay, so that's a good start. I guess because I saw keto diet first, I'll start with that. There's been some research on, so I'll just say answer live instead of type answer. There's been some research, including at Stanford, on the keto diet for bipolar disorder and schizophrenia. And the studies have been, that study was positive. But I have to say that they have a fairly restricted range of people who are eligible for the study. So I have had patients enroll in the study, and not all of them have been able to complete it. Also, I guess the question is keto diet instead of medications, for which I would say no, absolutely not. Keto diet in addition to medications, possibly. But the keto diet, I was just seeing a patient today who has bipolar disorder and is also a medical student at another medical school, but in California, so I'm still able to see him. You know, brilliant and very motivated, but he's had difficulty. And he can cook, doesn't always have time to cook, and so as he gets busier as a medical student and doesn't have entire control, for example, if he's doing a rotation at the hospital, can't always bring his lunch with him. It's very difficult to stay on the keto diet. And he's someone who, he has a breath test to see. So, there's, I would like to be able to say definitively, yes, go and do it. But honestly, it's difficult to be on. So keto diet instead of medications, no, do not do that. I do not recommend it. Keto diet in addition, if it's going to cause more difficulty in your life, then, the data on a small study of very carefully chosen patients, as I said, a lot of my patients who I've referred to the Stanford keto diet, they've not been able to continue. So as soon as, it's very easy with just a little bit of carbohydrates to get out of ketosis. It takes a while to get into ketosis and no time at all to get out of ketosis. Basically, the whole idea of a keto diet is to have the body switch from glucose, which is the natural energy that it uses, over to burning ketones. And it's not, there are theories about why this might work. But, throughout most of human history, we've used carbohydrates to help. So anyway, it's difficult. I can answer some more on that. Let me go. I'm sorry. What was the next one on Q&A? I'm answering some of the Q&A and then going to the.
The question was about mitochondrial health.
I'm not sure I know enough about that to answer, but I guess I will start with the idea that, I'll have to hear a little bit more about it, but any sort of diet Instead of medications, no, I don't recommend. In addition to, possibly, I'd have to hear a little bit more about mitochondrial health. There have been, and so some of the things that are actually helpful in weight loss are um, are helpful for weight loss. But in general, and a nutritionist can tell you this, diets, which are temporary, are difficult, and whether it's for weight loss or attempting to help in psychiatric conditions, um, they're temporary. It's probably better to adapt healthy eating habits, which often includes a lot of variety. And so restrictive diets are more difficult. Um, it's difficult to do a keto diet that's plant-based. And I think that the research on um, plant-based diets for overall health is quite good. And those aren't being touted for improving mental health, but they're, I think, good for overall health. And I think also it's worth noting that some of the diets that are proposed are not really sustainable for the planet as well as for each of us as individuals. So I can try to answer more if the questioner wants to say more about the mitochondrial health. But again, not instead of medications, possibly in addition to. I'd have to hear a little bit more about it, but trying to be not too restrictive. Okay, so getting to the webinar chat, let's see. Address how medications have changed for bipolar disorder and hopefully improved over time with less side effects. Yes, so when I was in medical school, there was lithium, which is still a mainstay, and interestingly is more natural than anything in the health food stores. Lithium is an element, is the first naturally occurring solid element in the periodic table, but has definite side effects, especially if taken in amounts more than prescribed. So one of the difficult things about lithium is there's clearly research that it's helpful in preventing suicide. It's very helpful for bipolar disorder, but if you have a desired level of lithium, which is about 1.0, that's good. If you have 2.0, you start to get terrible side effects, and 3 or 4 times the recommended amount can cause, serious kidney problems, thyroid problems, can even be fatal. And it has lots of side effects, and we can talk about the side effects. So then from lithium, then we got to the anticonvulsant medications, valproic acid or Depakote being one of the first ones. And they've turned out to be pretty good. It's kind of based on the kindling hypothesis. Kindling is known to be true in epilepsy, where the more seizures somebody has, the more seizures they will have. It tends to sort of train the brain to have more episodes. Kindling appears to be, there's a good kindling hypothesis, but it's difficult to prove, but that people who have a bipolar episode, a manic episode, or a depressed episode will have more of them. And so if you can prevent them, then people are less likely to have them over time. And if you allow them to happen, then it makes it more easy. Then the antipsychotics, which were used all along but had a lot of side effects, the newer atypical antipsychotics have gotten better. And, lithium was very difficult for the kidneys. Depakote is very difficult for the liver. And the atypical antipsychotics don't need the same kind of blood monitoring. So I'm kind of skimming over, 50 years of medication history. So the side effects have gotten definitely less over time for some of the medications. Um, and, some of the medications, as for example, the atypical antipsychotics have had more weight gain than the older ones. Um, a lot of people would argue that between, say, tardive dyskinesia, which is very stigmatizing and doesn't necessarily go away without treatment, um, weight gain, although it's a health problem, it's also not as stigmatized. It's shared by, you know, more than a third of American adults, possibly half, possibly more. Um, so that's kind of a quick answer. I love these questions, so I'm going to answer them as quickly as I can. And I love that you prefer this. I hope it's personalized and less about, PowerPoint. What's your experience with Cobenfy in regards to schizoaffective bipolar type? I am looking forward to being able to prescribe Cobenfy. At this very moment, I don't know how many patients that I am jumping through hoops. I'm doing backflips. I'm doing prior authorizations. Stanford was one of the sites for testing Cobenfy, and the patients have done very well. The main side effects of Cobenfy, which xanomeline, the main medication in it, was developed for Alzheimer's, and it did very well cognitively, and it doesn't work at the dopamine receptors in the way that everything else does. So movement disorder side effects, weight gain side effects, it doesn't appear to have those. It appears to be possibly better for cognition. And at least one of my colleagues said that, one of her patients who isn't just on Cobenfy, but was added Cobenfy in addition to his existing antipsychotic, she used to have to give him like gummy bears to keep him in session. He would keep getting restless, and then she realized on the most recent visits with Cobenfy that he stopped doing that. He's able to pay attention. He's related. He's this is a patient that we've shared. I took care of him in the hospital, and so he's had very serious symptoms, including violence. And now with the Cobenfy, he's doing much better. So I've been very, very, I've been very encouraged with that. Just getting to the next one on the webinar chat, and I'll pop back over to the Q&A ones when I can, but I'm trying to do them more or less in order. What's the best way to come off risperidone? That's a great question. If and I guess one of the things is, what are you going to and why are you coming off the risperidone? So if it's because of lack of efficacy, then I would switch to something that's different enough. So for example, sorry, I'm getting ahead of myself. Branch point. Are you coming off of risperidone because of lack of efficacy or because of side effects? Because if you're coming off of because of side effects, then I would switch to something that has fewer side effects. If it's because of difficulty with compliance, then the long-acting medications have really good, really good data in terms of compliance. The studies out of Scandinavia, you can look it up, Tiihonen, if I'm pronouncing that right. The medications that did best in terms of relapse prevention, not having to go back in the hospital and also functioning better. These huge studies, over 20,000 people, the kind of studies they can do in Europe that we can't do in the US, because, they have national health insurance. And so the data is easy to collect. And in Scandinavia, people don't tend to move around much. So they can do these long-term studies. The Tiihonen studies show that two types of medications do better than the others. the long-acting injections and clozapine. So if the problem is lack of efficacy, then that might be where you want to go next. When you do switch from one medication to another, go gradually. If you're switching over to clozapine, of course, it takes a long time. And there are times where you can go stop start. You're on one medication that didn't work as well for you on Tuesday and you're on something else on Wednesday. But and sometimes if there's an emergency, then you have to do stop start. If someone develops a terrible side effect, let's say bowel obstruction, and they have to be on something else, then you don't have the luxury of crossing over. So going down on one while going up on the other. But if at all possible, do a cross taper instead of stop start. Actually, I can't figure out if I mirror image or whatever, but anyway, going up on one and down on the other. How long do functional bipolar patients need to be on meds? Is there a way to phase it out? That's a good question. And if people are doing well, I have a long conversation with them about if it's okay to stay on medications. Medications are no fun. I agree. But I've also seen people where they've tried to go off the medications and they didn't do well. And so tell me if this analogy makes sense. I wear glasses. I've needed glasses or contacts since I was in third grade. And I would really rather not need them. And in terms of stigma, as an adult, there's not much stigma. But when I was a kid, people made fun of me and called me four eyes. But if I tried to just go without them, then if I tried to go without them, then I would drive into trees. And so I've come to just sort of appreciate, and most importantly, in terms of at the point at which people made fun of me for having glasses, I desperately didn't want glasses. And, I got contact lenses for a while. Now I feel like I get up in the morning, I put on the glasses. They're kind of a hassle. They get fogged up. They need cleaning sometimes. But I'm not an inferior person for needing glasses, for needing help. Once I get the help I need, and if it's the correct prescription, then I'm just as good as anyone else. So if the reason for being off of the medications is the stigma, I guess I would think about that. Anyway, the glasses analogy doesn't work for everybody. I know at least one parent who wanted the medication off for a young person. The young person didn't actually dislike medication, but when I used the glasses analogy, the dad said, I got LASIK. So I don't know. There is no LASIK at this point for psychiatric, for schizophrenia or bipolar. Okay. My son takes Abilify 10 milligrams for the last 5 years and on more regular for 3+ years. Now he wants to discontinue medication. He says he's stable. The cause is weight gain. He gained almost 80 or 90 pounds in the last 8 years. What are the alternatives for medications that I can advise? I don't know how severe the symptoms were before, but yeah, so off and on, more regular for the last 3 years. Weight gain is a problem, but there are treatments for it. I have to say that the majority of the patients that I've had who've stopped medications for schizophrenia or bipolar, who stopped them for weight gain, didn't do well. And I've had primary care doctors who said, "Oh, you should stop the medication." And sometimes I call them up and I talk to them. I was associate dean at Stanford for a couple of years, 2.5 years during the pandemic. So, well, I don't. Let's just say I've been in this area a long time, and I've dealt a lot with other types of physicians. And of course, in medical school, we had to treat all types of patients, and I continue to treat people through their various symptoms, waking, and so forth. So I've had people who have switched to a different medication and lost 80 or 90 pounds. I've had people who, so it's not your son's fault for gaining 80 or 90 pounds in the last 8 years. 10 pounds a year is no joke. But there are alternatives to going off medications altogether. Metformin is something that's been around for decades. It's used to treat diabetes. It does not lower blood sugar directly. And, so you won't go into like an insulin coma or something if you try that. And it's pretty effective. The medications that people are taking now, if you can get insurance to pay for them, 80 or 90 pounds is worth, an insurance company should authorize payment for the GLP-1 drugs, the ones that you see on television, Ozempic and Mounjaro and all those. And I've had people do quite well on those. So I have a bunch of people who have done well when stable, staying on the medications that help them be stable, but also so either switching to something else or getting something for weight gain. So, one of my patients who has done well on clozapine, brother, same diagnosis, had a very scary episode of violence. And so when my patient, not the brother, but my patient, primary care doctor said, oh, his cholesterol's up, I think he should stop his medication. And I said, what, do you have other patients who are, whose cholesterol is like, yeah, it's like the majority of my patients. Like, what do you do for them? And then he said, well, I can put them on cholesterol lowering medication, stuff. I said, yes, how about we do that? And that actually helped that patient a lot. What are the statistics on suicide rates among individuals diagnosed with both schizophrenia and depression? This is a very good question, and it underscores what I've been talking about when I'm saying, I'm cautious. When we're talking about side effects, that is important, but there's very few side effects that are worse than losing your mind. As you know, I went into this field, at least partly because of a friend, a medical student, who died by suicide. And at that time, there weren't the modern medications. I wish he had stayed with us a little longer, because I think he would have been one of the people who would have done well. But, weight gain is a bad thing, but it's shared by a lot of people. Like I said, probably the majority of Americans are trying to lose weight. Some of the other side effects are more difficult to treat. So the suicide rate for schizophrenia is not point prevalence, not like at this moment in time, but in a lifetime. The data has been that about half of people with schizophrenia will attempt suicide at some point in their lives, about half. And then the more recent data is a little bit better, but at one point a few years ago, about 20% would die by suicide. So that's more fatal than heart disease. That's more fatal than many types of cancer. So I would say that chasing after the side effects, many of which are treatable, by stopping the medication, which is treating a really difficult, really awful illness. Yeah, that's what I think. Sorry, I get emotional easily, and it matters to me. It means a lot to me. So thank you for asking that question. And then it says diagnosed with both schizophrenia and depression. The rates for schizophrenia I have memorized. The rates for depression are also high. If the questioner asked meant both schizophrenia and depression, that, so a schizoaffect, either schizophrenia and depression separately or schizoaffective disorder, depressed type, that's it's imperative to to treat these illnesses. Can people with schizophrenia lose sensitivity to clozapine or risperidone over the years where the meds stop working well even at higher doses? For risperidone, yes. For clozapine, knock on wood, I've had people doing well on clozapine for years. And, people who are functioning very well. I've also had people who have been on risperidone or other medications for years who are doing well. So it's possible. It's not as common as what people talking about depression say, like they call it Prozac poop out or so forth. One thing that you should be sure to look for if somebody, especially, is abruptly losing efficacy to something is to look for drug-drug interactions. Clozapine is very sensitive to drug-drug interactions and even food-drug interactions. So if someone seems to be less sensitive to clozapine, so they're taking the same dose, there's no problem with compliance, but they're less sensitive, check a blood level and see what's happening there. And I wish we could be a live audience, so I'll just quiz you in your head. Common dietary interference with clozapine, grapefruit. So had a patient who had gained weight on clozapine and then had terrible symptoms again. The voices were telling him terrible things. He couldn't be out and about because he thought that people could hear his thoughts, and he was crying. And then I said, did you lose weight? And he said, yes. And this was before the pandemic. And then I said, what did you do? And he very proudly said, I've gone on the grapefruit diet. So grapefruit, not other citrus fruits, but specifically grapefruit, interferes with what are called the cytochrome P450 enzymes. And so grapefruit juice, that causes clozapine to be metabolized more quickly. Any specific trainings for therapists for these disorders? Yes, there's cognitive behavioral therapy for psychosis. There's specific training. We have a number of people at Stanford, psychologists who are trained in CBTP. How to gently encourage clients to try medications for psychotic symptoms can only do so much in talk therapy. Yeah, so one of the big things is to sort of let people know that it's not an either or thing. It's not black and white, and it's not even like you can choose, I don't know, you can do this or that. You can do both. This is true of depression, where medication plus therapy works better than either alone. For depression, which isn't our main topic today, the national trials, STAR-D, talking about depression, found that especially if there was a childhood history of trauma, that medications alone would not work as well. And so you needed to address both. My son is with bipolar and alcohol problems. After he was relapsed, he is in rehab. His psychiatrist started naltrexone. Now he's on lithium, risperidone, and naltrexone. How long can he take naltrexone? He can take naltrexone as long as it's needed. And, it's helpful. What are pros and cons of taking naltrexone with bipolar medications? What methods do you recommend for dual diagnosis? So for dual diagnosis, you really need as much help as possible. Dual diagnosis with only medications probably isn't going to work great. Addiction treated with only therapy worked for some people, but not everyone. And so the medication-assisted treatments for alcohol, for example, so that includes naltrexone, it includes acamprosate, and it includes antabuse. Those work better than either alone. Well, my thing says my computer's about to restart. No, don't. Snooze. Okay. If I suddenly disappear, it's not because I've stopped liking you or anything that anyone said. It will be because my computer restarted. But I think I managed to put it off for a little bit. How do you feel about switching clozapine to Cobenfy? Clozapine has been the gold standard for efficacy ever since it's been developed. So if I switch from clozapine to anything else, it's because of side effects, and it's as gradually as I can manage. So if everything's good on clozapine, I would stay with clozapine. If everything's not good, then I would switch over gradually. And remember what I said about, one of the major side effects of Cobenfy right now is pain in the wallet. Insurance companies tend not to pay for it. I hope you have really good insurance. So as I've written for it, I never take people off of the last one. I keep people on it until they actually have Cobenfy in their hands. For example, I have a patient who's after we did backflips said that their insurance would pay for it. And so I said, great. And then he said, can I go off? I said, let's wait until you actually have it. So I went to the pharmacy and his copay was $1,700. What is that? $50 a day. So the base price was like $100 a day, but that's still unaffordable. So I saw that patient today as well, and we're going to try to get the Cobenfy. Looking at Q&A 2, please. Yes. Oh yeah, we're up to 10 now. Thank you. So I talked about keto. How do we differentiate ADHD and bipolar? Both are similar, especially in women. There are some interesting differences. I like that he talked about women and men because, oops, I just accidentally, I don't know what I just did. Okay. I switched from Q&A to something. So one of the interesting things about bipolar, but oh yeah, thanks for talking about women, because of our hormonal status, which can often be protective, people have always kind of used our hormones as, I don't know, it was kind of, people would disrespect us because we have hormonal shifts. They're actually quite protective. The later onset of schizophrenia in women, average age is 25 to 35, not average, sorry, peak age of onset, and 18 to 25 in men with schizophrenia. A lot of that is probably, a lot of that is some protection from the hormones. So societal expectations, hormones, there's like a lot of things that, women are not just, small men. So ADHD. One of the big things about bipolar is its cyclical nature, whereas ADHD tends to not have, periods of depression, periods of mania. Really, if there's anything that is specific for bipolar, it is during mania a decreased need for sleep. So not like insomnia, like I'd really like to go to sleep, but I can't. But I don't need sleep. I'm good. I have all these awesome ideas. So people with ADHD can also have, ideas that are sort of unrealistic and so forth, but it tends not to go in phases. And then you can do fairly good testing for ADHD. So not just the symptoms, but there's a whole bunch of tests that are helpful for looking at ADHD, and they are both sensitive and specific. So a neuropsychologist doing ADHD testing, I think, is sort of the gold standard, rather than just answering, 9 questions, which can't possibly, not anyone's fault, but can't possibly be as accurate. Oh, and then, by the way, the treatments for ADHD and bipolar are quite different. So someone can have both. Some unfortunate people do have both. But in general, stimulants can make ADHD better. They're often the first choice treatments. And stimulants tend to make bipolar much worse. Um, and so, yeah, there is some overlap. And I have made that mistake before where someone said, I really need an ADHD medication. Turned out they had bipolar. I felt very bad because I made their symptoms much worse. What is the max dosage for lamotrigine for a 20-year-old weighing 145 pounds with bipolar 2? Currently on 400 milligrams. I would probably, rather than saying for this specific patients, what's the maximum dosage, 400 milligrams might be right. Remember, with lamotrigine, you have to go up very slowly. So that's already a pretty high dose. 20 years old are pretty resilient, healthy, and 145 isn't a lot. So bipolar 2, which doesn't have mania, mania, but kind of more tilted towards depressive end of things. I think for that person, lamotrigine might be the best medication because lamotrigine tends to be not as helpful for bipolar mania, but good for depression and pretty well tolerated as long as you go up slowly. Remember, the issue with lamotrigine is Stevens-Johnson syndrome, this like rash that's not just, I don't know, minor rash like when I get bit by mosquitoes, but like mucocutaneous, actually very dangerous rash. Other than that, if you go up very, very slowly, remember 25 milligrams a week or slower, and then if you add Depakote, you have to go half as fast, twice as slow. Half the dose, yeah. You got to go as slow as possible. So 400 milligrams, you're right, is a high dose. I would talk with the psychiatrist about that because this might be the max dose or it might not be. Remember, I kind of started out by saying I'm not going to treat, unless you're already one of my patients, I can't treat you here. So I hope that's helpful, but let me know if there's some more things. Okay, still going on Q&A. Ever see microdose, for instance, with long-term Haldol injectable? Loved one gets a panic feeling, almost physical feeling in chest. They last almost 2 months before symptoms return. Thinking a microdose could be better than side effects that make them not take meds. That's an interesting question. So a microdose of Haldol, like a little tiny bit. So I do have some people taking a little bit of antipsychotic on an as-needed basis in addition to a long-term injectable. That's worth considering. So, 25, maybe 50 milligrams of Seroquel is not a full daily dose, but for some people that's helpful. If their injectable is Haldol, your little dose in between might be something other than Haldol. If we sort of put things on a big chart with medications that are similar to each other and different, you would want something that's maybe different. When a person is hearing voices, will you suggest ways to discuss this with him? His schizophrenia. Yeah. So part of what's CBT with psychosis is about is managing the voices. If the medication has been helpful but the voices aren't gone, then sort of the amount of distress associated with the voices, and sometimes also the voices, can be helpful. As you're talking to a loved one that has voices, letting them know that if they talk with you about it, you're not mad at them, you're not going to blame them, you don't think badly of them. That's an ongoing thing that's very helpful. At the beginning of this, Ravina mentioned family to family and peer to peer. Some of these skills are talked about in those programs, And then if you have a CBT for psychosis trained therapist or a psychologist who, has treated other people with voices and is able to sort of talk with them. So some of it will be kind of, the thing that doesn't work is to say, stop hearing voices. Don't hear voices. Are you hearing voices? Stop hearing voices. That doesn't work, right? Actually, I'm trying to think of if that works for anything. Um, you know, but for voices, um, being able to have a conversation and say, yeah, that sounds. If you argue about a delusion, that's difficult. But if you empathize with them about the feeling of it, it's sort of like, it feels like you caused the car accident. That's really scary, and then talk with them about it. So I answered that one. Cobenfy, only daily. How long does it take if someone stops meds to get return of symptoms? That is a great question. A lot of it depends on the severity of their illness and also, um, frankly, how long the medication lasts. There's some that have a really long half life, and so if they stop the medication, you have some protection. Um, I remember a mom who actually, again, the patient herself didn't want to go off the medication, but the mom was sort of like, yeah, she looks really good now, so I don't really. The mom had, um, a fairly stigmatized view of medications and really didn't think that her daughter needed it. But then, when her daughter missed a dose of a long-acting injectable, so the daughter had been living elsewhere and was on injectables and was doing pretty well. And then the mom said, she she's been off it for a week now. She can't have any left in her system. It's like, actually, the whole idea of a long-acting medication is to last for at least a month. And if you think of the half-life, the amount that it gets to half of the original dose, um, you know, help me with math. 2 to the second, 2 to the fourth, 2 to the third, fourth, 2 to the fifth is 32, right? So 1/32 or 3% of the original dose, 5 half-lives. So if the half-life of a long-acting medication is, say, a month, then it would take 5 months to get down to 3% of the original dose, right? So, I had to tell the mom, I said, actually, she still has most of the medication in her system, even though she missed, Tuesday's dose and now it's Thursday. So, doesn't get their long-term shot. Okay, clarification. Doesn't get their next long-term shot because of side effects in and out of the hospital. Any med to address the side effects. So address the side effects because it will take a while for the long-term shot to get out of their system. That's how the long-term shots work. So if, depending on the side effects, if it's movement disorder, work on that right away because it's very, 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 very unpleasant. If the side effect is weight gain and things like that, you might not have to go right at it because those are long-term side effects anyway. So I hope that was okay. Oh, sorry. Cobenfy daily. Yeah, it's a once daily medication. Remember, it's like 50 or 100 of xanolamine and then 20 of trospium. So the trospium only acts below the brain and the rest of the body, and it addresses the so the desired effect is getting into the brain. The undesired effects, the side effects in the gastrointestinal system, are fought off by the trospium. Okay, so I think I answered that. Assuming no long-term injectable for Cobenfy, that is correct. Just came out. Let's see. To do a long-term injection, they would have to do both medications in it. Unless someone's really clever, I don't see that happening anytime soon. That's 2 medications they would have to be able to inject at the same time. My son has schizophrenia, but he's not realizing it. Yeah, that's such a common problem. It's part of the illness, isn't it? is to not realize, is to feel like there's something wrong with the world rather than I have something that I could get help with. He's on medication, but he doesn't like it. Keeping asking not to take it. Should I make him realize it, and how? There's a book by Javier Amador, Amador, called "I'm Not Sick, I Don't Need Help." I think I mentioned at the end of that. There's others that are about this. It's very much a part of the problem is not realizing the illness. I mean, part of paranoia is feeling like everybody else is wrong. And so you guys are already in NAMI. When people are not in NAMI, I try to get them to join and to work peer to peer and family to family. I think is very helpful if he'll do it. And y'all realize it's free. And then this is something that we all work with. Oh, I should do a shout out. There's a social worker named Annie Tiberio, and she is on Instagram. So how do you spell D Tiberio? Ditiberio. She does a really good thing. It's called You Need a Social Worker, and she works with families and the patient themselves about it's hard to be on medication. Medication is, I've been saying how good clozapine is, but it also has the most side effects, right? So it's Charles Dickens who said it was the best of times, it's the worst of times. The clozapine's definitely both, right? Lots of side effects, but also most efficacious. So should I make him realize it? Hard to make people realize things. But don't give up on them, and keep the conversation going, and let him know it's not his fault that he has the illness. If part of the reason he wants to go off the medication is because of stigma, at least letting him know that, ill or not ill, you love him. You love him no matter what, unconditionally. And that you want his life to be, if the enemy becomes you or the medication or so forth, that's terrible. If he realizes that the symptoms, the things that have kept him from living the life that he wants to live, that's the enemy, the illness, the symptoms, and you're on the same side. So I realize it's easier said than done, but try to keep that shared goal. The goal is he wants to do this with his life. His goal is he wants to meet someone. His goal, those are shared goals, rather than the goal being you got to take medications. Because then you'll just keep arguing about it. It's like, when you were taking the medications, these things were going a little better. My son has schizophrenia. He was prescribed Invega. Is that a common medicine for this condition? Yeah, it is. And if it's Invega Sustenna, that's one of the best long-acting ones. Orally, because it's the metabolite of risperidone, so it's in the oral form is it's not that it's not quickly absorbed, but it's quickly metabolized. It's quickly peed out of the body. It has basically no drug-drug interactions with other things through the liver. And so it's a really good medication, but taking orally, it doesn't last that long. So the Invega Sustenna is really good. He's quite well, but he has lip smacking. Okay. So the lip smacking is probably a movement disorder from the medication. So he can either get one of the new medications that's helpful for, so Ingrezza and Austedo are two of the ones for tardive dyskinesia, or switching to one that has less of this side effect. So it could be Invega. Another long-acting one that doesn't have the side effects as much is Abilify. Abilify has other side effects, such as maybe more weight gain than Invega, but that might be the right thing for your son. But again, because I don't know any of you, and there's probably details that I don't know about, and also feel free to clarify. If I'm answering something and it's kind of like, no, you didn't consider this, then please speak up. Thank you for all your input. Aripiprazole was reported to improve prolactin elevation. Yes, that is true, because it's not a dopamine blocker. Dopamine used to be called prolactin inhibiting hormone until they realized it was the same medication. They called it PIH. However, after 10 years, if there's increased prolactin and no other cause, do you think that's the cause of it? And it can also affect DHEA and as such lead to infertility. Is it progressively reversible when DC replaced or tapered down? If after 10 plus years there's increased prolactin and no other cause for it, so you want to make sure that there's no other cause for it. There may be, increased prolactin can also happen from other things. So you want to check that out. Progressively reversible yes, it can be. You want to taper it down, and you also want to so aripiprazole or brexpiprazole. Remember, aripiprazole, was the first of the partial dopamine agonists. And then, another one to consider, if you can get it, is Cobenfy. So prolactin elevation, it can affect fertility. It absolutely can. Prolactin, the way you remember the side effects of prolactin elevation is it's the hormone that inhibits lactation. Prolactin is the hormone that promotes lactation, right? Prolactin. So everything that happens in a nursing mother will happen with prolactin elevation. So breast engorgement, which doesn't sound like the worst thing for women, but it can be painful and can be uneven. And of course is very intolerable for men. Sometimes production of milk, but also infertility. The periods often don't come back for a while after a woman gives birth, but also more so if she is breastfeeding. And so prolactin elevation, even when there's no baby, decreases fertility, decreases sex drive. Let's see, I can't see you all, but is it too much information if I say that after I gave birth, the OBGYN asked me what I was doing for birth control, and I said, the baby. And she said, you can still get pregnant during this time. It's like, no, I don't think so. Anyway, as many of you can tell, I use humor as one of my defense mechanisms. And one of the things that I've always liked about NAMI is the sense that we're all in it together, and that whether it's humor, crying, being with each other, joy, tears, all of that, that the sharing of the experience is part of it. So hope that wasn't TMI, but back to the and humor actually helps memory too. I have medical students come back decades later and say, I still remember that because it's if it's dry, it's hard to remember it. So prolactin can cause infertility, can cause decreased sexual function, can cause erectile dysfunction, can cause loss of libido, anorgasmia, all of those things. So aripiprazole is better than some of the other ones. After 10 years, you might want to check and see if there's something else, and maybe change to brexpiprazole. Maybe see if you can go to Cobenfy, which doesn't do anything directly at the dopamine system at all. So, everything worked at dopamine, everything was a dopamine blocker. Then the dopamine partial agonists came along, like aripiprazole and brexpiprazole and cariprazine, Vraylar. And those all are supposed to cause less prolactin elevation. But then Cobenfy doesn't act at dopamine at all. Okay, where are we? Haldol microdose injectable was thought. What were you thinking? Microdose injectable. Oh, I thought you meant like they're on Haldol injectable, and then you use like little microdoses for like orally to help with, some of these feelings in the moment. I have not used microdose injectable, and I'm not even sure what the dose would be. It's an interesting question. I mean, one of the things about injectable medication is that it's hard to give like part of the vial, and so if it comes in a very low dose and you use that, then that's one thing, you use all of it. But if you try to inject half of a vial, part of the way, and I don't want to get too detailed on this, but part of the way a lot of these are long acting is they're not what's called they're a non-Newtonian liquid. And so if you give half of the amount, you don't necessarily get half of the medication. Am I making sense? If you give 10% of the vial, you don't get 10% of the medication. If it's a long, sticky substance in there, then it might all be stuck in the vial. Some of them are in little microspheres. Some of them are attached to fatty acids. So using part of a vial, you get very, you don't necessarily know how much you're getting. So microdose injectable, I would use, if you're trying to use the lowest dose possible, I would still use the lowest dose that's available and then use the full vial, if that makes sense. Where am I? Same person. Are some people more sensitive to meds and need lower dose? Yes, absolutely. The sensitivity to medication depends on a lot of things. Genetically, there's things, our liver enzymes are very different from each other. Just to use an example, not even kind of a psychiatric medication, alcohol. I am Asian. I am among the 75% of people in my ethnic group that are extremely sensitive to medication. It's not just because, or not medication, to alcohol. And that's just one of the many, many things that people can have different sensitivities to. Of course, there are allergies. Of course, there are, all medications have side effects in some people and not in everybody. So some people do need lower doses. And so I can get into more of this, but in general, lower body weight, but not 100%, because the active, it's acting on our brains, and our brains are not as different in weight as we are as people. Women are often more sensitive, not 100% of the time. Older people, so very young and then older, are more sensitive to the healthy young adult. And then, of course, if we have other conditions, then we can often be more sensitive. And as we talked about before, drug-drug interactions, food-drug interactions. So a lot of people do need lower doses. Let's see. I've got some, I'm still on Q&A, and then I'll switch back over to the new ones on the webinar chat. What are the most important factors contributing to long-term stability in a person with schizophrenia? Oh, I love this question. Adequate treatment, which includes both medications and therapy, and social factors. Some of why women in general do a little bit better than men, women with schizophrenia do a little bit better than men, is maybe our hormones are protective. But part of it is that we often have formed, started a job, completed our education. The difference between 18 to 25 as peak age of onset and 25 to 35 includes finding a life partner, having gotten started in a career, having completed our education. And so all of these things are helpful in long-term stability. stable living situation. If you're not in a stable housing situation, it's almost impossible to be okay, right? It makes everything difficult. So, you know, social support and adequate treatment, I would say, are the most important factors. Um, Heart physical feeling is the side effect in Haldol injectable. Um, well, Haldol does have quite a few side effects, so I'm not sure what you mean by heart physical feeling. If you mean palpitations or so forth, um, but but yeah, that can be a side effect of Haldol, oral or injected. Um, and then, please clarify if I didn't get that quite right. My young adult daughter is stable on her bipolar medications, including metformin, but weight gain is increasing, causing social anxiety and now disordered eating. Can a GLP-1 weight loss drug be prescribed before she meets the criteria for obesity? We know it will get there eventually. Oh gosh. Um, I've been doing a lot of backflips to get people GLP-1 medications. So can it be prescribed before she meets the criteria for obesity? I hope so. Work with your doctor on getting that um, and calling and filling out the forms and all that, because waiting for them to get all the way to obese, from overweight to obese, um, like you said, it's causing other problems. Um, in addition to the forms, I often will write in, you know, just like what's happening. So in this case, you've given some really good, vivid details. Um, and, disordered eating, describe how bad the eating is to them, describe how the social circle has gotten less and so forth. So um, I tend to, maybe because I'm old fashioned or just because I'm stubborn, I tend to call up the insurance companies myself instead of just doing the form. And then I try to talk to a doctor. They call them MD to MD. So I try to talk to an actual doctor. And one time when they were sort of like, what, and the person on the other end of the line couldn't spell schizophrenia, couldn't spell the medication and so forth. But, you know, and they said, what, um, what happened on the previous medication, the cheaper medication? And I said, he held up a radio station. And the person said, how do you spell that? And it says RADIO space. And then they were like, oh. So yes, they held up a radio station. And so we got the medication. Okay. Is it okay to use a long-term injectable in conjunction with clozapine? Yes. And actually in the Scandinavian studies, those people did really well. There was a really big difference because obviously people don't go on clozapine as the very first medication, but they had the biggest difference between how they were doing before and how they were doing now. And they tended not to get relapses. They tend to not have to go back in the hospital. They tended to be functioning better. And actually, there's studies that either long-acting or clozapine or both, they actually live longer. So even with all of these side effects like weight gain, which causes, it's not just a cosmetic issue, it's also a health issue. And yet schizophrenia itself is more dangerous. I know some people, NAMI members and psychiatrists who went to the Food and Drug Administration to testify, and so now there's no longer the REMS requirement. What's REMS stand for? I'm blanking on. But anyway, the weekly blood draws, and then every 2 weeks, and then every 4 weeks. So if you haven't heard already, those are no longer required. And they looked at the data, and so anyway, they had T-shirts, matching T-shirts that said, clozapine is the safest medication, and obviously clozapine is a very effective medication for a very dangerous illness, but we don't give it to everybody for everything. So I didn't get a T-shirt, but I very much respect the people who did that work. including NAMI members, to go and tell the FDA to let this very effective medication be used for a very dangerous and difficult illness that's causing a lot of suffering. Please speak about Seroquel and schizophrenia. Seroquel is very effective. It's not the gold standard like clozapine, but it does well, and its main side effect, which is drowsiness, can sometimes be a desired effect. And so in many ways, it's been well tolerated enough that people were overusing it for sleep, but it turns out it can cause some weight gain. Early on, there was a worry that, what was the big thing? Seroquel, there was this concern that it would cause arrhythmias, and it turned out that other than for long QT, a genetic and rare illness, it doesn't cause as much EKG abnormalities, heart arrhythmias as some of the older medications. It doesn't cause it as much as, Haldol or Mellaril. So Seroquel is very effective for a lot of people. It turns out it's being used because its safety profile is pretty good as long as you use it for appropriate things. It's been used a lot now. I think its use in uses other than schizophrenia has eclipsed its use in schizophrenia, but it's still pretty helpful in schizophrenia. Thank you about the microdose thinking, bummer, the vial percentage issue. Yeah, sorry. Math comes back and haunts me. I was on the math team when I was in high school, so a lot of these things are like math. Whether you like it or not, it's still there. Okay. What have I gotten to? Okay, I'm back to the webinar chat. Is olanzapine close in treatment effectiveness to the new drug you're trying with some of your patients? Olanzapine has always been pretty good. It was never clozapine without the side effects, but in the CATIE trial, comparison of antipsychotics trial of intervention efficacy, CATIE. So Stanford was one of the sites, and olanzapine actually, there were like different phases of CATIE, and so clozapine was if you failed for efficacy on one of the previous medications. Olanzapine did really well in the first one. It was also used in higher doses than the others, so it might not have been completely fair, but olanzapine is probably one of, is efficacious. It's also got, more weight gain than any of them. Is it close in treatment effectiveness as a new drug you're trying with some of your patients? That is not, we don't have the answer to that. Because they didn't do a head-to-head trial. So not sure how you spell it, Cobenfy. So Cobenfy. I also won the spelling bee when I was in, sorry. I don't know who came up with that name. I wouldn't have spelled it that way. Cobenfy. Same manufacturer as Abilify, so they like things that end in FY. Olanzapine so far is the only med that has been most effective for my son's schizoaffective bipolar 1. He's been on it for about 5 years, seems to be losing some of its effectiveness, 20 milligrams a day. Would Cobenfy be similar in effectiveness or a good alternative? I would keep the olanzapine and then start thinking about other things. Does that make sense? Don't go off of the olanzapine, but talk with your psychiatrist about Cobenfy as a possibility, and then go over, gradually. My son has gained over 100 pounds, and he's on clozapine and depakine. Yeah, so this is also one where Cobenfy might be a good option. Tell the insurance company that as you're making the switch. Don't make the switch until you've got the Cobenfy in hand, and then very gradually go off of the other ones. One of the big problems is clozapine causes weight gain, Depakote causes weight gain. The two together, it's not your son's fault that he gained 100 pounds. Oh, the whole idea of fault, remember this. The one thing that I do like from my slides is I have a picture um, of these mice that they're not on olanzapine or clozapine, but they have the serotonin 2C transporter, I'm sorry, not transporter, receptor knocked out. And so they're kind of on permanent clozapine or olanzapine, if that makes sense. They're not actually getting the drug, but those medications act at this receptor and this has been knocked out. So they block the receptor when you take the medication, and these mice have it. And so that's the one thing I'm missing from the slide set, is that there's a picture of a mouse that's not a knockout, what they call wild type, and it looks kind of mouse shaped. You see the little point where the nose is, and then a tail comes out this end. Okay, and then the mouse on the knockout mouse, the mouse with 2C, is spherical, and so you can't even, the nose isn't even nose shaped anymore. And then there's a tail coming out the other end. That's the only way you can tell which end of the mouse is which. The reason I like that slide is to let people know it's not your fault. You know, there's no morality involved. Mice are mice, And if you feed both mice the same amount of mouse chow, the fat mouse will still gain weight. How is that possible? Calories in and calories out. The mouse with the knockout, the spherical mouse, moves around less. They've actually videotaped them, and the computer shows how much they're moving around. The regular mouse, runs around like mice do. If you've ever had mice in your house, which I did in my med school dorm, they never stop moving at night, and they rustle around. The knockout mice, who are very cute, by the way, they get in a comfortable position and they stay there. And there's a different a nap mouse study. So the mice with the 2C knockout, which is similar to being on clozapine or olanzapine, they don't move around as much. They're less anxious than the mice that move around, but they don't burn off the calories. And then not mice, people, when they looked at, there's a study in the British Medical Journal, I can't remember the author, but when they wired people up with special underwear, people who were, quote, naturally thin, but didn't identify themselves as exercising, people who were naturally not thin, the naturally thin people burned off 500 calories a day from just moving around. So I can't do the annoying thing that some people do with the pen, but they would be doing that. If they were on the phone, they were on the phone like this instead of, staying in one position. So all this is to say, you, your loved ones, anyone who has gained weight on the medication, very subtle differences in their thermostat, their basal metabolic rate, and very subtle differences in activity level can cause weight gain. So when somebody tells me as a doctor, I'm not even eating that much, they might not be lying, okay? And I think so a lot of the questions have been about weight gain. I think the most important thing that I can impart is not a specific diet or a specific medication or a specific thing to switch to, but to realize that this is a common problem and it's not somebody deserved it, or, if we take the judginess out of it, if we take like the morality out of it, that's already something of a help. That you and your loved one, you and your doctor and loved one, everybody is on the same side, right? It's not like somebody's gaining weight just to spite you or just to spite their own body. Maybe the single most important thing about weight gain. What is the max dosage for? Oh, I talked about this already. Not sure for this particular person, but you can check with your doctor. 400 is a high amount, but it might be right for this person. I have a bipolar adult daughter and grandchild with ADHD. Can you discuss genetics due to concern about potential bipolar with grandchild? Yeah. Okay. So studies at Stanford, Kiki Chang, Carrie Ketter. The most common uh, diagnosis early on that then changed later on in people with a family history of bipolar was ADHD. Um, so remember earlier I was saying, well, at some point the difference in sleep um, can be more specific for bipolar. Um, Early on, kids have funny sleep patterns. It's hard sometimes to tell what's happening. Um, so the genetics, again, most common. So there's like bipolar adults with bipolar kids, but there's a certain number of bipolar adults with kids with ADHD who then later on develop bipolar. So it's a good concern to have and to raise. Um, so this is going to be this is not going to be like a single conversation. This is going to be an ongoing conversation. Um, Very helpful to have um, the grandchild and the daughter's healthcare team be in communication with each other. Because if the left hand doesn't know what the right hand's doing, um, the grandchild might be started on a medication that's not that helpful for them. And so, um, yeah. Uh, my daughter has been stable on Lamictal and Geodone. However, weight gain is getting uncontrollable even with metformin. Is there a chance for her to function more rather than isolating herself? Yeah, this is a difficult one because some of the obvious answers are, the person with Depakote and clozapine, both of those cause weight gain. Lamictal and Geodone are already supposed to be relatively good, and you're already getting metformin. This would be something where any insurance company which says that they don't need one of the newer obesity drugs, I would fight that because this is something like you're already doing all of the low hanging fruit has been picked. Okay, you've done all of the things that you're supposed to do, and she's still gaining weight. So this is, and then isolating herself. That's so sad because when somebody gains weight and feels stigmatized and then isolates themselves, then of course there's fewer chances to be active, and then that leads to more weight gain. So, um, as much as possible, I would say that this is someone who any insurance company that isn't allowing you to get the obesity drugs for her, she's already on metformin, she's already on Lamictal, which is better than Depakote for weight gain. She's already on Geodone, and she's stable on these medications. So the most doctors would not say to switch from something that she's not stable on. Here's where if the newer medications for weight gain hadn't been invented, that's one thing, but they are invented, and so they can't work unless she has access to them. So, yeah, I'm not going to tell you to yell at the insurance company because then I'll get in trouble. But if you yell at them, you will have my sympathy. Tori, yes, Fuller Tori wrote a book about schizophrenia. The psychiatrist in the locked ward in San Jose asked my husband and I to buy this book so our son could read it while he was hospitalized. He read it in one day. And at the next meeting with the psychiatrist, he said that so many things Tori talked about in his book were what our son was experiencing. That was the beginning of his realization that he had mental illness. We were so thankful. Yes, thank you for mentioning Fuller Tori. He has been, gosh, how many years has it been? I used to hear about him when I was in training, so thank you for mentioning that. I mentioned Javier Amador, who's a little younger. He's closer to my age, but Fuller Tori has been doing this forever, and he's been an advocate. So I should have mentioned him from the get-go, but thank you for bringing him up. How are we doing on time? I'm going to keep talking as fast as I can.
We are
Riviana?
8:29.
Okay.
So we'll let you ask your questions.
I got to the end of the webinar chat. How are we? Any trials about Cobenfy for bipolar type 1 to date or used off-label? Of course, you're not supposed to use anything off-label, right? Pretty much all of the antipsychotics that have been helpful for schizophrenia have turned out also to be helpful for bipolar. So, I'm supposed to say if I'm saying anything off-label, that was just off-label. But yeah, everything that's been tried for schizophrenia has also been shown to be helpful for bipolar 1. There's enough overlap in the symptoms that that I would expect that copanfy would be helpful. There may be trials ongoing. I don't know about them. I was involved in research in the past. I'm not involved in direct medication research right now, or I'm like a sub-investigator on a couple of things. Dr. Rona, my son became schizophrenia at 17. We believe it started at 15. He's regular with medicine, and I'm trying to find a therapist. We're a close-knit family. What can we do to better ensure he does not lapse back into psychosis? You're already doing one of the important things is to recognize what's happening. And getting a therapist is going to be very helpful. At the risk of being biased, we have some really good child psychiatrists at Stanford who are knowledgeable in schizophrenia, because not every child psychiatrist treats schizophrenia. So, if your insurance authorizes Stanford, try. I'm going to get in so much trouble with my colleagues. It's sort of, what did you say? But I think getting a therapist who is experienced with treating schizophrenia is going to be helpful. And then family therapy, and of course, NAMI. NAMI, I recommend NAMI. I'm not just saying that tonight. I say that all the time. And then I think, did I get, not quite done. Okay, 3 more. Aside from genetics, is anything known about why a person developing schizophrenia in late teens to early 20s? Genetics is part of it. But remember, even in identical twins, it's about 50-50. 50-50 is more than, the 10% background rate. No, sorry, 1% background rate, 10% in. So, genetics is definitely involved, and yet there's also other things. There can be a sensitivity to certain types of stress. So, trauma is, schizophrenia and PTSD aren't the same thing, but they can often develop at a time of great change and stress. So the answer is not to put people in a bubble wrap and not get stressed, but going away to college. And again, I'm not saying don't prevent your child from going to college, but a lot of times these are during stressful times. The other thing, and this is preventable as much as possible, is drugs of abuse. There's studies that are done in New Zealand that I don't have time to explain in detail, but a certain type of genetics, interacts with marijuana use. Harder drugs might probably be worse, but it's hard to do those studies. So studies with cannabis are relatively easy, at least in New Zealand, assuming people answer honestly. If you have a genetic predisposition, if you use pot and you don't have a genetic predisposition, your rate of developing schizophrenia is about the same as the background rate. But if you do have a genetic predisposition and you use pot, goes way up. So since you can't do anything about your genetics, staying away from drugs of abuse is a really, really good idea. I know it's easier said than done, but when I talk to, a lot of the Stanford students, they party like everybody else does. Oh, and I wish that party meant like flirting and dancing and that kind of thing and not. But anyway, party now seems to mean using drugs. I tell my Stanford students, it's sort of like, okay, maybe your friends used pot and they didn't get psychotic, but if you used it and you got psychotic, life's unfair. Okay, you can't use it. It's like going out and getting a sunburn. It's sort of like your friend who doesn't get sunburned didn't get sunburned with the same amount of sun, but you wouldn't be able to go out. So you are the mental equivalent of the sunburned person. You exposed to the same drug of abuse, you got psychotic. So yeah, aside from genetics, late teens to early 20s, please, please, please stay away from the things that help you think outside the box. Unfortunately, for some people, they get out of the box and then they can't get back in. So I would be very careful. The brain is a very delicate thing. And so, anything that, and by drugs of abuse, I mean, if people are talk about it getting smashed, getting hammered, any of these things that are, fun because you get out of reality, you might want to get back to reality. My son is with Stanford. Okay. Um, good. I'm glad. Dr. Apurva Bhatt. Yes, that's exactly. I wasn't going to get in trouble if I mentioned her name, but she is she is awesome. Actually, that might be a good way to if she doesn't get mad at me for like recommending her to everybody. I think that's a good way to end. And we're at time.
Yeah, yeah. So thank you so much, Dr. Hugh, for answering all these questions. There were so many of them, and we had close to 60 people who had attended. So this is really great information, and we've live streamed it. So anyone who's missed tonight's presentation can always go back and take a look at it. But really appreciate you giving all the time. And thank you again so much for spending all this time and answering each and every question. And thank you
We got
everyone
to
who
all.
attended. Yeah, and we really enjoyed your sense of humor. So, that
Oh,
stays.
good. Oh, good. Yeah, I feel like life is difficult. If you don't
Yeah,
have a sense of humor,
that's so
yeah,
true.
I'd rather laugh than cry whenever possible. I do both. I cry when, I mean, you saw me start to cry a little bit today when talking about certain things. But um, let me see if I can think of this quote. Shared pain is diminished, shared joy is enhanced. And NAMI, if anything, is about getting through difficulties by being there for each other.
I
And
absolutely
so,
agree.
so humor, love, joy, got to have all of that.
So well spoken. Thank you so much. I think, and thank you for, when you're answering questions, you mentioned about family to family. I do want to reinforce these programs are amazing. They're all free of cost. And, if you are interested, you can go to our website and check them out, get more information about it. But again, thank you for all your time and answering all the questions, and hope to see you in person sometime.
Yes. And thank you, all of you. Thank you for your questions. Thank you for your openness. And thank you for doing what you do.
Thank you. Have a good night, everyone, and we'll see you in June now. Our next general meeting will be in June.
Good
So,
night.
bye, everyone. Good night.
Bye.
Bye. Thank you so much, Dr. Yu.
You're very welcome. Thank you for inviting me.